So I think the number one thing to think about in terms of adverse events with the disease-modifying drugs and the biologic DMARDs that we're using in rheumatoid arthritis and similar diseases is infection, and it always has been. These drugs target the immune system. These diseases are diseases of an aberrant immune system, and you try to control it by targeting the immune system, and as a consequence, you run the risk of reducing response to infections of various sorts. And that's been the issue from day one. I think that, with increasing experience, increasing use, we've come to realize that risk is not nearly as great as we once thought. It doesn't diminish the potential toxicities of medications, but it makes them more user-friendly, if you will. You understand what to be concerned about, and certainly it's become very clear that the risk-benefit ratio weighs heavily in favor of the drugs, that the risks are minimal compared to the tremendous benefit that many of these drugs give. We've also learned over time that you can attempt to abrogate those risks by looking at the patients, looking at the people you're considering the drugs for. There are people who are going to be at higher risk for complications and infections. There are many of the people you would think of already, people who are older, people who have concomitant diabetes, people who have other, cardiovascular issues. The other thing that's very clear is people with severe disease and systemic disease are at higher risk. And that's been sort of interesting and a learning point with a lot of the biologic therapies, that the risks are different depending on what you're using them for. So for example, we use TNF inhibitors to treat rheumatoid arthritis, to treat ankylosing spondylitis, to treat psoriasis, to treat inflammatory bowel disease. And it's become clear over time that the risk of infection is highest in those patients with rheumatoid arthritis and inflammatory bowel disease because they have a greater risk of disease to begin with because of the systemic impact of their underlying disease. On the other hand, those patients with AS or with psoriasis, for example, there's much less systemic impact of the disease, so their risk of infection sort of a priori due to their disease is much lower, and so we don't see a huge increase when you add on a biologic therapy. The other interesting thing we've seen and learned over the years is that the greatest risk with some of these DMARDs, for infection at least, is really during the first 6 to 12 months of therapy. There may be a couple reasons for that. One is that there are certain people, a population of patients who might be at greatest risk, and they get into trouble early and they stop the drug, and those people who are still on the drug after 6 months are lower risk, and that's a possibility. The other, which I think a lot of people think, although we've never been able to prove it convincingly, is that early on you have a risk of infection that's related to the disease and a risk of infection related to the drug, and as the drug works, the disease risk goes down, and so the overall risk goes down because you're left with just the risk of the drug and not the disease. But it's as we develop new drugs, I think we learn about new toxicities that are unique to those spaces and those drugs. So, on the whole, we say, well, biologic DMARDs, even non-biologic DMARDs, increase risk of infection. There's an increased risk of skin cancer in some of these patients. We know that. But then every once in a while something unique comes along. So we see JAK inhibitors, we see Zoster, which we haven't seen to a great extent with a lot of our other drugs. So there's something unique about inhibiting the JAK pathway that triggers, Zoster, and it triggers those reactions. It doesn't mean you can't use those drugs. We need to be aware of it, and things change. So in the past, we've said, well, that's a problem, so we need to vaccinate our patients and vaccinate them against Zoster. Well, the problem was up until now, the Zoster vaccine, Zostavax is a live vaccine. It's a live virus vaccine. You don't give live virus vaccines to somebody on biologic therapy. And so if they're already on therapy and you're going to switch them to a JAK inhibitor, you're kind of stuck. You have to stop their treatment for a while and vaccinate them. Now we've got a new vaccine, the Shingrix vaccine, which unfortunately hasn't been tested in our population to a great extent, but I think people are becoming reasonably comfortable with it. And because it's not a live vaccine, you can give it to people who are already on some of these therapies, so that if you do want to vaccinate somebody who's going to go on a JAK inhibitor, you have that opportunity. there's not much you can do for bacterial infections, for pneumonia, for sinusitis, those sorts of things. But the rule of thumb is that for some of the atypical infections, you can screen your patients, right? So that certainly we look for a history of latent TB in anybody on a TNF inhibitor and virtually any biologic, because we know those patients are at risk for reactivation of TB, but we need to screen them up front, and we can do that. There's less consensus on screening for some other issues like coccidiomycosis in the Southwest or atypical mycobacterial infections, because it's a little harder to screen and it's a little harder to know what to do with those patients, what kind of prophylaxis. If you find somebody who has a history of TB exposure, you know that you can give them 9 months of isoniazid, reduce their risk of reactivation, and safely give them a biologic therapy. It's a little less clear what you can do with somebody who might have an atypical mycobacterial infection in their past or an atypical fungal infection. How do you do something about that risk? That's still a bit of a challenge. The other risk to watch out for are concomitant therapies. And honestly, I think the biggest one that people tend to lose track of is prednisone, steroids. And perhaps the single biggest added risk for infection in our patients is patients who are still on steroids. Even low-dose steroids increase that risk, and in many cases, if you can add additional biologic therapy or more aggressive disease-modifying therapy and get that patient off of steroids, you've actually done them a favor. You've reduced their overall risk of infection. You certainly reduce their risk of other steroid complications, from osteoporosis to skin thinning to cataracts to everything else. I think the cross-talk and the cross-pollination comes when we kind of recognize the potential risks. And as we learn, we get newer therapies, newer targets that we're going after, I think we can learn from our R&D colleagues and other colleagues what risks to think about. So a perfect example is actually the TB risk of TNF inhibitors. It caught us a little bit by surprise, but actually, in retrospect, after we started to see cases of reactivation of latent TB, we heard from our pulmonary colleagues and even some ID folks that they said, well, why didn't you guys expect that? Because, TNF maintains granuloma formation. And if you break up the granulomas in the lungs, you're going to get reactivation of TB. Why did you guys not expect that in the first place? And it was there. The other one more recently, and not so much in the RA space, but in spondyloarthritis, are the IL-17 inhibitors. And we see candidal infections in patients on IL-17 inhibitors, and it turns out IL-17 plays an important role in sort of maintaining sort of host response to candidal infections. We don't see a lot. We don't see systemic candidiasis, but we see more thrush, vaginal candidal infections than we would otherwise consider. And it's not a deal breaker. It doesn't keep us from using the drugs, but it's something we have to be aware of as we manage those patients, and something we have to talk to patients about so they know what to expect or what to watch out for. I guess I wouldn't say expect is the right term, because most don't get anything. So I think it's important to make sure that they're aware of the issues, right? Clearly, we have to think about the multiple medications they're on. If they're on a lot of drugs, to look at combined risks. There are, some of the biologics, the IL-6 inhibitors, might increase risk of transaminitis, hepatic transaminitis or potentially liver disease. And so when you use that drug with methotrexate, which is another drug that can cause liver disease, you have to be very cautious. Doesn't mean you can't, but it's just it's an issue to watch when you have sort of combined or sort of cross risks that are shared by a couple of drugs. The other thing, though, I think is really important when you're working with patients is to make sure they understand what, and I don't like to frighten them, but I need to know they understand the risks that are there, so that if something does come up, they don't ignore it or look for another explanation and miss an opportunity. What I often tell, and I remind my patients, but I also tell other physicians, non-rheumatologists who are not familiar with these, is that, in our patients on biologic drugs, they may show up in the ER, they may show up in an urgent care center with a fever and a cough, okay? And that's usually going to be bronchitis or community-acquired pneumonia. But it could be TB. It could be, coccidiomycosis. It could be something unusual. And if you don't at least think about that and are not aware of it, you're going to miss it.